there right now.
Sure. Again, thanks for having me. I'm Patrick Cahill. I just joined the Hartford Healthcare Medical Group 4 months ago in the Infectious Disease Department. And since that point, I've been seeing inpatients and outpatients and consultation for infectious diseases. Much of what we've been doing lately, unfortunately, has circled around COVID, and we are really excited to finally see the results of the vaccine trials and fortunately be able to roll these out as soon as we are. To start with, the vaccines are coming out as far as the efficacy and safety profiles much better than everybody had thought several months ago. Informal polling amongst my colleagues, people were optimistic that we might get somewhere in the range of 70 to 80% efficacy as far as the protection against COVID with these shots. And the data from the Pfizer and Moderna trials has been much better than that, showing greater than 90 and closer to 95% efficacy as far as protection against coronavirus. The safety profiles have been excellent as well, under 1% of patients in both of the trials, both of which were relatively diverse and included patients with pre-existing comorbidities and risk factors for severe disease. Both trials enrolled around 40,000 patients and had low rates of serious side effects. The side effects that we are seeing for the most part are injection site reactions and potentially fevers. There are some much rarer ones that are not well sorted out as far as the likelihood of reproducibility among the general public. So most of the side effects have been relatively low in the first round of the vaccine. So both of these vaccine regimens are 2-shot protocols. So they will require a second follow-up vaccine for full efficacy. Most people are getting some injection site soreness, low-grade fevers, which unfortunately can mimic some of the earlier stages of COVID. So we've been trying to sort out how to best approach those people that get symptoms that may mimic the actual disease after these shots. So we're recommending that people, first of all, with any comorbidities or risk factors for severe disease, that includes ages greater than 65, any history of cardiac disease, diabetes, lung disease. We're recommending that everybody get these shots. If people are to get any sort of side effects related to them, then the first step would be to call their physician and discuss what symptoms they're feeling and how to approach from there. But we would recommend coronavirus test within a few days of getting that shot, just to see if we're dealing with active disease, which would actually be a contraindication to proceeding with the vaccine series at that point. Basically, from our standpoint, infectious diseases, we're viewing these vaccines as extremely beneficial, low risk, and the side effect profile is much better than any clinical illness that we're seeing that makes its way to the hospital, at least related to the coronavirus.
Okay, perfect. Thank you so much. Patrick McCormack from Uncas Health. Does anybody have any questions, first of all, for Dr. Cahill at this time? All right, perfect. Okay, so Patrick, I know you have a slide presentation.
Sure.
Make sure we can see that.
There it is.
Perfect.
All right, so everybody can see. So just once again, I'm Patrick McCormack, and I'm the Director of Health for the Uncas Health District. We cover 11 municipalities, Norwich sort of being the hub, but we cover 10 others in the surrounding communities, including Griswold and Montville. We go out to Lebanon, Voluntown, Preston. So we're covering a wide range, just under 100,000 people. We're very fortunate that we have great partners in the community, many of which are on the call today, and not the least of which is Backus Hospital, which I can't thank Dr. Cahill enough for participating. I always feel like I give the vaccine for dummies version, and then Dr. Cahill comes on and it's sort of like the honors vaccine version. So it's great to have somebody with that clinical knowledge to be on the call with me today. I do have, just to give you a perspective on how frequently things change and how frequently I get updated on new information. I was saying earlier, I was on the Council of Governments call. We had a representative from the State Health Department, and I had information on that meeting that I wouldn't probably have had prior to it. We have I think it's 1 o'clock today. We have another State Health Department call, which we'll be getting a vaccine update at that point. And then at 2:30 this afternoon, I have the Emergency Management and Homeland Security update, which will also include some level of a vaccine rollout update. So that's just today alone. And each day the information seems to be new and changing. So this is as of what I know right now, which I said by the time we're done may be a little bit different. So we can go to slide 2, Angela. So we're talking about, at least for the Uncas Health District, we've been talking all along about our role with critical workforce in terms of getting vaccine out to people. Critical workforce can include private industry, which is healthcare providers, state agencies, municipal officials, federal officials, education folks, which is state, public, and private. And that alone has always been interesting because as far as registering, we've talked about having a municipal entity that will register everybody in a municipality. But as you all know, there's, NFA isn't necessarily part of the city of Norwich. NPU or Uncas Health District are sort of quasi-city, not really part, but yet they are. So agencies like that, when they put these state, public, and private designations, we all know that we may fall into one or the other. So we talk about the lack of clarity sometimes in the information, and it can be confusing for people. And then it's critical workforce infrastructure, which can be the public works crews, the public utilities crews, people that keep our streets open and keep our lights on. Congregate settings, so those high-risk populations, long-term care facilities, folks like that. Other essential workers, and we've talked even to the hospitals, places that have said, where they consider essential. Environmental services continues to be one we hear frequently. I know when I most recently talked to Backus, they pointed out that they have environmental services folks that are dedicated to the ICU unit. So obviously they're critical to the infrastructure around COVID. And I would not have necessarily thought about that prior. And non-congregate settings, high-risk populations. So those could be like the Houghton Coves, the Sachem homes, the Martin houses, the Leffingwell houses. So folks that may be more at risk for comorbidities, but they wouldn't necessarily fall under a state-run facility. Angela, next page. So the background on our current status, and again, this is even probably a week or so old as we speak, but they have the Advisory Committee on Immunization Practices, which recommends the vaccination in the initial phase, which is considered 1A. And what they've talked about is trying to vaccinate healthcare personnel. So those are all paid and unpaid persons serving in healthcare settings who have a potential for direct or indirect exposure to patients or infectious materials. So I know Backus, as an example, has started that process of vaccinating their folks. Residents of long-term care facilities, so those are the people that reside in those locations, which include a range of services, including medical or personal care, or persons who are unable to live independently. My understanding is those vaccinations will be contracted through either CVS or Walgreens. And they're going to do what they call a bed-to-bed vaccination process within those facilities. So essentially a left to right or a right to left, or however they're going to go about it, to make sure that they get everyone within that facility in a given period of time. And they said that in addition to that, now first responders at risk of exposure to COVID-19, which includes EMTs, fire, and police who respond to medical 911 calls, are being included. That's been a little bit of a confusing piece for all of us, I think, because what's happened is the rollout has occurred through information from the health districts, from the state health department, the hospital EMS coordinators have been sending information out. But after my discussion this morning, What I think the important message is that they are trying to saturate the community to make sure that people have as much access to the information as possible. So when they talk about these particular folks registering, putting in rosters and being available for clinics, I think the goal is to have those particular agencies be registered somehow. Our understanding was it would have been easier for the municipalities to register folks. But what we were told today is even if a fire department has already registered or has connected with the hospital, as an example, and they have a plan for being vaccinated, that's really the goal. So worry, I guess, less about how they're getting the information and more that they are getting the information. So as far as phase 1B, which is the essential workforce folks, the details are still yet to be determined. In fact, we had one document that we received about a week ago that said, take all numbers and information with a grain of salt. So that gives you some detail. We talk about the details are as clear as mud in some cases. So page 4. So details on how the vaccines will work in the early rollout. So there's going to be a clinical role, which is setting up clinics in what they call the Vaccine Administration Management System. And then we'll publish available vaccination slots. So as an example, the local health district will fill a role in that way. Some of what we've been doing to this point is identifying locations within our communities, within the region to serve as vaccination locations. And it can be as simple as us at this point asking for a floor plan so we can determine a flow of patients. And then we had to, as of yesterday, give the information on which facilities we intend to use, whether or not we've received a floor plan, do we have a flow of patients through the facility, and how quickly do we think we're going to be able to vaccinate people going through the system. I believe most of us in the districts have decided that we're going to use what they call strike teams. That will allow us to identify a few vaccinators to go out to each of the facilities in the hopes that we'll be able to provide facilities within various parts of the region. So that, as an example, you aren't going to necessarily need to be in Lebanon and drive all the way to Norwich to get your vaccine, that there may be one further out west that will be available to those folks. And what they will do is the employers will register with the Connecticut Department of Public Health, and they'll upload their rosters of eligible employees into that VAMS system. So that's really an important role for employers. We had messaged out to our municipalities asking if they could have one person identified as the scheduler role. And most of our municipalities have done that. But like I said, some departments have already registered separately. And what the state says is that's okay. They just want to make sure that they're in the system. So then what will happen with individuals? They'll be able to schedule their appointments from a broad range of providers and clinics. So those may be through the hospital, Backus in our area, non-hospital based, which may be the federally qualified health center. It may be through the local health district. It could be through a pharmacy down the road or through a private provider. So again, appointment slots are likely to be limited and scarce at first. So people shouldn't be getting concerned that they either haven't heard back. In fact, even the VAMS system was supposed to notify employers within 48 hours of registering. They would send an email and you would then upload your roster. People were getting concerned because it was 3 or 4 days, and they said right now, just due to volume, it may be an additional few days before employers get an email back. Next page, please. So key planning assumptions: 1, Connecticut is going to get a limited number of doses at the discretion of the federal government based on national evaluation. The governor has set up a vaccine advisory committee who will review the need throughout Connecticut. And then that committee will make recommendations based on those ACIP guidelines to the governor and the Department of Public Health. Supplies are going to increase gradually. We keep hearing about the orders being placed. So we had initial orders had been placed for the hospitals. I believe it was December 4th was when those initial orders were placed. Additional orders are going to be placed on the 21st for some of these more public clinics or local health district based clinics in the hopes that around Christmas or the week after, some health districts may start receiving vaccine based on who's capable, how much vaccine is available, and where they are going to be vaccinating. So next one, please. So the key planning assumption 2 is the vaccine will either be a licensed vaccine or authorized for use, which I think to this point, and Dr. Cahill would know better than I would, I believe it got emergency use authorization already for the Pfizer, and Moderna is authorized already or is in the process?
Not quite yet, but it should be very, very soon.
Very good. So that means a vaccine that's an EUA is close to being approved, currently being tested or issued under public health emergency, which seems to be what's happening here. Next slide, please. And then number 3 is the process of maintaining vaccine quality via cold chain management is different for each eligible vaccine. So I'm sure we all know that the Pfizer has the ultra cold requirement. Moderna doesn't have the same level of requirement. So the type of vaccine being received in Connecticut plays a role in both availability from different vaccinators, which can include storage and handling capacity, and it impacts our ability to schedule the clinics. So, it'll tell us whether or not we, as a vaccinator, have the capacity to manage the vaccine. We've asked questions like, is it going to be single dose vials? Will it be preservative free? Will it be multi-dose vials? Will it have preservatives? Because those are the types of questions we're going to get from the public. And also, so our nurses know how they will do the just-in-time training, what types of protocols and procedures they'll need. Will they need to pre-fill syringes or will they come pre-filled? And that'll also help with the timing of getting people through a clinic. So clearly, if we have to spend the time to fill syringes, we have to allocate that time during the process. We also want to make sure we don't lose vaccine. So it's always an issue of if we pre-fill, how many do we pre-fill? Are people really going to show up? Are we going to get enough people through the clinic? So I ask people just bear with us as we start the process because we will be learning as we are doing. And that's always a difficult process to go through in the beginning. So there'll be a learning curve and there'll be bumps in the road, I'm sure. But we just ask people to be patient with us. And it's not something we haven't planned before. We've done, you can move on. But we've done H1N1, we've been planning clinics and we've done drive-through flu clinics and done them every year. So we have the process in place, but clearly this is unique and we haven't been through this complete process before. So there'll be a learning curve associated with it. Another planning assumption is current vaccines are 2-dose vaccines, which will be administered either 3 weeks or 4 weeks separated in terms of those 2 doses. That means the individual will need to make 2 appointments to become vaccinated, and individuals should receive the same type of vaccine for both doses. So that hopefully will be managed well in that VAM system, or I believe Backus will be using their EPIC system, but that will hopefully allow people to see within the system when their next appointment is. It will help in terms of making that appointment. And again, it's going to be first come, first serve for those appointments. So if, as an example, Norwich Public Utilities were to upload the list of all of their staff members, those individual staff members will get an email offering them locations where they can go to become vaccinated. My one caveat to that is, as an employer, I would suggest you have a conversation with your employees if you have a preference on when they become vaccinated. I know there's been concern about, if people were to have soreness or fever or just not feel great a day or 2 after receiving the second dose, primarily I think is the issue, that they don't want to lose an entire staff or an entire shift of people all at once. So if you have expectations on your staff to be vaccinated, in different groupings, then I would just make that clear with them up front that you would ask of them to make their appointments at a certain schedule, and you may want to assist them with that. Next slide. So the administration of COVID vaccine will require this phased-in approach. Obviously, there's going to be the projected short period of time when we have very limited doses. And then our hope is that we will start to have a sufficient supply to meet demand. And as that supply increases, we'll be able to expand the number of people to receive it. And we'll also be able to include those commercial sector partners, which include those pharmacies, doctors' offices, and clinics like mine. And then we'll be able to do it through either mobile clinics. You may see it in a senior center, or you may see it in a school, which is already a point of distribution site. It may be a drive-through model, or it may be an in the facility model. So a lot of that's being worked out right now. And it can be as simple as a weather dependent issue. We may want to bring people through a drive-through model, but under the circumstance with the weather, as it will be on Thursday, we may think it's just effective to bring it indoors and do it as safely as possible. And then eventually we'll have that excess supply. We'll be able to open vaccination clinics and administer through those private partner sites and maintain the other sites where they're needed. But our goal in public health departments is not to be the vaccinator of choice. We want to be able to fill a gap within our community. So we are more than happy to not have to provide those clinics if it's necessary. We'd like to know people can go wherever they want to be able to get vaccinated. I think that's my last of those slides. Is that correct? There we go. The only other couple of comments, and this is hot off the press that I heard at my last meeting. The question was asked about the percentage of population that they'd like to see vaccinated for effectiveness. And Dr. Cahill can certainly weigh in. The number that I heard was within 12 months, they'd like to see 70% of the adult population vaccinated, but I'll allow Dr. Cahill if you have a different perspective.
Yeah, I would say at least that. And we would assume that with that percentage of people vaccinated and the natural infections that have occurred, that's going to drive our community transmission rates very, very low.
Yeah, and just to talk about some of the complexity of how this all gets rolled out, one of the comments made during the last meeting was, how are they going to identify which groups get the vaccine next? And they said, well, we're waiting on the advisory committee for vaccination to advise the allocation committee to let the governor's COVID-19 vaccine advisory group make that decision. So it just talks about the layers that need to happen. My hope is it allows people to feel more confident that there is a process involved in being able to approve these things. And it's not just, at somebody's whim, but that, there's really some thought that goes into this. So they said, and they reassured me that they're still not sure who will be in phase 1B, but there has been some additional discussion around folks like lower income people, people in higher risk areas being prioritized more than they may have been in previous documents. And they did say, again, if a department applies separately of the municipality, don't capture that roster separately within the municipality. And I'm speaking to anybody municipal wise on the call. So as an example, if the Norwich Fire Department or Norwich Human Services registered prior to the municipality starting to upload rosters, they said don't do it twice. Rather have the first one be in, and then the municipality can just verify that they already are in the system and just sort of check the box to make sure that they're not sort of forgotten, but that they are just acknowledging that they've already uploaded and received the information. So that's my initial presentation, and I'm happy to answer any questions.
Patrick, did I hear you say that you had already decided on places in Norwich?
We had worked out some locations that seemed to make sense, and we're hoping we had the approval.
Oh, okay.
We had to upload yesterday, so I'm hoping that we'll stick to the ones. We gave the caveat that, we believe these will be the locations, but it's not firm yet. And I think you and I probably have a conversation about a couple of those locations.
Okay. And do we have a scheduler for the city of Norwich? Do we know who that person's going to be?
Yes, your human resources director will be the scheduler for Norwich, is what I was told as of
That is
yesterday.
not me.
Are you happy or sad? Yes, very happy. Yeah, Bridget is what I was told is going to be the person for the city.
So I've been getting a couple of questions that maybe you guys could help me out with. One was, people have been asking me, will children be getting the vaccine, or will all the adults be vaccinated and then they'll look at children? And the other question people have been asking me is, how long do the side effects tend to last for? So I wondered if either of you could help me on those two.
So as far as the side effects, those are transient, so to speak. So within a couple of days, those should be gone. They've seen some people get some swollen lymph nodes, usually on the same site as the injection, that may be there for about a week. But as far as the fevers and the muscle pains, that should not be present for more than 2 days. But we'll see more information with that as it becomes more widely available. I think as far as the question of children being vaccinated, they're of the lower risk group for developing clinical illness. So I think they're not going to be among the higher priority groups, but eventually that'll make its way down to them.
And I had to go through my notes to see, but I believe, and correct me if I'm wrong, I think the Pfizer was initially approved for age 12 and up, and the Moderna was initially for age 18 and up. But that's what I heard.
Patrick, there's a
I will go to Angela's question about, do people who have had COVID or didn't know about the positive antibody tests still need the vaccine? So the information I have on that is experts don't know how long someone is protected from getting sick after recovering from COVID-19. They said that the immunity someone gains from having an infection, which is that natural immunity, can vary from person to person. And some evidence suggests natural immunity may not last very long. And we won't know how long the immunity produced by the vaccination lasts until we have vaccine and have more data. So, all of those questions being asked, they said that if your body develops an immune response, which is the goal of vaccination, there's a possibility you may test positive on an antibody test. It indicates you've had previous infection. So they said that experts are currently looking at how the vaccination may affect antibody testing results down the road. But my understanding is that if you've had an antibody test before, you should still get the vaccine. Is that correct, Dr. Cahill?
Yeah, we haven't been taking historical antibody into account when giving people, when recommending that they take the vaccine. But it's likely that if you've had COVID within the past 3 months, then you're a lower risk of developing it going forward. Again, this is kind of in the realm of nobody really knows, but we're finding that out as we go along.
And then Chief Montoya had asked about, and he said Patrick, which is great because it could be either of us that could answer. But I think it was directed at me. Along the lines of not submitting twice as an individual organization or the municipality, how about through different entities, DPH versus Hartford Health? So to that point, what my understanding is yesterday, the EMS coordinator for Hartford Health or through Backus Hospital had sent out an email talking about vaccine for EMS providers. And that may have gone out through Hartford Healthcare System. So if it wasn't through Backus, it may have come from a different hospital, Wyndham, et cetera. And my understanding is if you did receive an email that you in all likelihood should respond and go through the Hartford Healthcare initially, because if you're doing through the VAM system and through DPH, then there may be a delay. You'd have to identify a clinic. Essentially, if Hartford Healthcare is offering through one of their hospitals, then they're telling you that is the clinic that's available currently for you. So I would say, make sure you go through Hartford Healthcare first because of it being an EMS provider. And then it may make sense to still register with DPH. And then my understanding is when you're vaccinated, those individuals would show up in the system as already having been vaccinated. So there should be some continuity between the vaccine administration systems to let them know that your employees have been vaccinated. But I think what's happening is Hartford Healthcare is identified through their network which people are appropriate or which agencies are appropriate to receive vaccine as first responders, medical first responders. And that's why you're getting that email and that's why you're able to go through them. So again, I'd go through Hartford Healthcare first, probably still upload your information to DPH so they have it, so they have your roster. And then one way or the other, whichever clinic your staff goes to, they would be identified as being vaccinated. Pregnant and breastfeeding women question, Dr. Cahill, I'll leave that one to you.
They are being offered the vaccine. That's going to be in individual risk assessment I would recommend that the patients reach out to their medical providers to kind of stratify their risk of severe disease at that point. It's not something that is well studied at this point, but it's likely that it would not cause any problems. So that's kind of in the realm of we don't really know at this stage because pregnant women weren't heavily included in the trials.
Then I had a question sent to me about serious allergies, whether or not you may get the vaccine. at what level of allergy is considered allergies. The understanding that I have, just in information I saw over the weekend, was the CDC on Sunday said people who've experienced severe reactions to prior vaccines or injectable drugs can still get the Pfizer vaccine for COVID-19, but should discuss the risks with their doctors and be monitored for 30 minutes after. So folks know we always ask people, especially if it's their first time getting a vaccine, to delay in leaving a clinic just to make sure they don't have shock or an allergic reaction. We also tend to have an ambulance on site, just so that way if something does happen, we have somebody who's there to provide immediate care. And I guess it's a shift because they said that on Saturday, there was a potential recommendation against vaccine for that group of people. They said CDC officials said patients with a history of severe reactions should take precautions because of 2 documented cases in British healthcare workers. But my understanding is that they now feel like it's appropriate for people to get them. Dr. Cahill.
Yeah, agreed. That was kind of a big warning that they came out with. And this is essentially a novel vaccine technology. The safety profiles have been studied for 10 to 15 years, and it is a safe technology. I wouldn't predict that if you've had a historical reaction to the flu vaccine, for example, that would carry over to COVID vaccine.
I always advocate for anyone who has concerns, always talk to your provider or a provider about any risks that you're concerned about. And then you always want to balance those risks against the benefit of the vaccination. And my hope is the vaccination benefit will outweigh what your concern is about your risk. But clearly talking to a medical provider is always helpful. There's a question about, do you know why there's multiple manufacturers of a vaccine? And any difference between them and a benefit of getting one of the companies over another. The thing that I saw, which I thought was the best quote that I heard, was a doctor, I believe they're out of Boston, Dr. Baruch, who had said there's 7 million people in the world, so we need multiple vaccines to be successful. It's not a race of one developer against another developer. It's a global collaborative effort. So from a public health perspective, I really appreciate that comment. Said I probably speak for all vaccine developers in saying we want these programs to succeed. And I know that people are concerned about the trials and the speed with which they happened. But I'm personally confident that the trials were done appropriately. That while they were expedited, it was because of the emergency need, not because they were trying to get one to the table before another. And I also know that the 2 that have been approved, there also are others that have yet to be approved. And some of those were ones that from a cost perspective, they really want to be at the table or available. They said that, some of them have greater ease with which they can be stored. So while those are probably the ones that are cheaper and more available, they have yet to be approved because of going through that process. So if that makes you feel any better, for those that are getting approved, there are also others that aren't. So it's not like everyone that's proposing a vaccine is then being pushed forward. There is a process they must go through. So Dr. Cahill, anything to add?
I agree with everything you just said.
And then they talk about, will a person's underlying medical conditions be accounted for in a prioritization receiving the vaccine shot? Does a person need to contact a primary doctor or specialist? So there's a lot of priority groups. Like I said, there's still a process being developed in terms of how they're going to decide who will be in phase 1B. But the World Health Organization had what they call SAGE values, and they had priority groups in there. And included in those are populations with significantly elevated risk of severe disease or death, groups in dense urban neighborhoods or living in multi-generational housing, social groups that are unable to physically distance, employment categories that are unable to physically distance, and healthcare workers at high risk, groups with comorbidities, older adults, and socioeconomic groups that are disproportionately higher risk of severe disease and death. So clearly the data is coming in daily. And I think that we're using a lot of that information to determine both who are the highest risk groups, who have been disproportionately affected by illness within our communities. And I think that will be the predominant reason that people will be listed higher than others in terms of getting vaccine. There was also a question about, have tests been done to determine vaccine safety for people with pre-existing conditions? And I don't know if Dr. Cahill wants to speak to that.
There were inclusions of people with pre-existing conditions that would confer a higher risk of severe coronavirus disease in the trials. It wasn't a high percentage of people. I'd have to double check, but I think in the range of 20% had at least one pre-existing condition that would confer a risk for severe disease. And in general, those conditions are not going to increase your risk of adverse outcomes related to a vaccine. So if anything, it would be more recommended to get the vaccine with those pre-existing conditions. There's nothing I'm particularly aware of, apart from maybe pregnancy, that is not studied to the point of recommending against the vaccine.
And we also had a question about, how will appointments be made for individual vaccine locations? Will it be alphabetical? Will a second shot be made at that time appointment? So like I said, I think the way it's going to work is you will be asked to go into the system, to have your name will be added to the system. You will get an email, and then the individual will at that point identify which clinic they want to go to. They will make an appointment for that clinic. And then it will be first come, first serve in terms of your scheduled time when you go to the clinic. As it becomes more widely available, I think it will be very much like it is for other vaccines, where you'll make an appointment with your physician, or you'll go in at a whatever time the pharmacy is available to get a shot there. And then the second shot, likely you'll get information either through like the schedules through the Backus Hospital or through the federally called health center, and you should be getting a reminder that your next appointment is due. In most cases, we'll be giving you some sort of a card to document that you had your first shot and that you're due for a second shot. And that's how we did it during H1N1. So you have a paper copy, but hopefully you'll be getting some sort of a digital reminder as well.
Patrick, on that question there, what if they end up missing the second dose? Is there like a time frame? If you don't do it, do you have to get both shots again? How would that work?
Dr. Cahill, do you know the answer to that?
I do not know the answer to that, but I think that it would be very wise to be making that follow-up vaccine appointment at the time of the first vaccine.
Sure.
And I believe there is some immunity associated with the first dose, Dr. Cahill.
Yeah, maybe in the range of 60%. So it's less efficacious with just a single dose, but you're going to get partial protection.
And another question I tend to get quite a bit is people that have already been ill with COVID and how they should be managed. So what they've been saying is, if you have a documented case of infection in the 90 days prior to the vaccination, that you may delay until they're near the end of that 90-day period. And that's, well, Dr. Cahill, you may want to speak to the 90 days if you don't mind.
That's my understanding as well, is that if your illness has been within 90 days, then we're pretty much going to push you towards the end of that time frame. But outside of that window, it would be fair game.
And it's been interesting because we have a lot of employers that suggest that an employee has to get a negative test to return to work. In fact, we had one large employer in the region that was requiring 2 negative tests to return to work. And just reminding folks that it's really a symptom-based and not a test-based expectation for quarantine. And people, and even in the beginning, we weren't aware, but people would test positive for up to 90 days after that initial test. So what was happening was people would complete the quarantine period, but then they'd go get a test and they'd continue to test positive. So they were finding it very difficult to go back to work, and employers didn't feel safe that they could allow that person to come back. And what I'll tell them, and even, how do I document as an employer that my employee did complete the quarantine? And what I've been telling employers is, look, they weren't in your place for the last 14 days. From an exposure point of view, you've eliminated that exposure at work. Whether they were going to the grocery store when they shouldn't have been, when they should have been quarantining, at least as an employer that they've completed the 14 days. There's no expectation on them getting a test to return to work.
Yeah, I would just add in that I would strongly advise against the repeat testing to return to work or to eliminate isolation. We've been trying to move away from that for some months now. So would not retest anybody within 90 days of an initial positive test.
And then in the chat, we have, with regard to educating the group of people, dental hygienists, TMTs, et cetera, to become vaccinators, do we know what the plans are for this education? I didn't know if there's anything in-house, Dr. Cahill. So from our end, what we're going to be doing is putting together a training for, especially for, as an example, we have our Medical Reserve Corps. We will be, we're very fortunate that we have some assistance from the nursing program at Three Rivers Community College. And it's been amazing. We've actually had calls from people that are nurses saying, look, I work in this community. I've heard they're looking for vaccinators, but I live in your community. If you need me, let me know. So I've already had, I think, 3 calls in the last day from people saying, I want to help vaccinate if I can be helpful. So it's been an incredible response already without even reaching out. But those people will get some level of training virtually, and then we'll be doing just-in-time training the day of the vaccination. And you know, for those people, they'll have a basic understanding of how to vaccinate. And our intent is to use our nurses and our medical providers initially that have most experience. But that being said, when the governor, or actually it was the commissioner, a couple of weeks ago allowed for expansion of who could do the vaccinations, made us in local public health breathe a sigh of relief to know we have additional vaccinators available to us, in particular people like paramedics. And there was an assumption that if they approve them, that there's a potential where they could help us to vaccinate their own population. So as an example, if American Ambulance has paramedics on staff, we have the vaccine, we could potentially bring it to them. Or they come to one of our clinics, they vaccinate their own people to take some of the pressure off of our vaccinators, and then they know they're done, they have a familiarity, and then they're able to work with them on getting that second dose. So I tried to work through, as an example, the fire chiefs to say, please, have that connectivity with your staff. Feel free to, message to them in-house. And if there's messaging you need from us, please do it. But they're going to be the ones who can pick up the phone and say, Jim, you're due for your second dose. You got to get down here today. We're all here. Where are you? Those kind of administrative level calls from a fellow volunteer fireman or whoever it may be certainly are helpful. Because if you get a call from the local health district saying, look, we have your vaccine available, where are you? It's not quite as effective as one of their colleagues in the department that are calling them saying, look, it's time to get down here and get your shot.
Patrick, if I can ask a follow-up question, and it's a clarification. We had heard that nursing students weren't legally permitted to give the vaccine because it's EUA, it's not a registered. So we were a little confused about, if there was an RN instructor with them, could they give the vaccine? But then we heard, other unlicensed folks were going to be educated. We just were a little unsure about what role could they play.
So I will check and I will get back to you, Edie, because your people are so endemic to our work that I want to make sure that we use them if we can. So my hope is yes. And, as the folks that we've used in our drive-through clinics that you provided have been part of our plan all along. Mm-hmm. So my hope is that it won't be an issue, but I'll check and make sure.
All right, thanks.
Robert Bell, you had a question? Oh, we still can't hear you for some reason. Do you want to put it in the chat? Okay.
A great lip reader, but I just couldn't make out all the words.
Anybody have another question in the meantime?
Hi, yeah, we've been getting a ton of questions from readers at the day, and I had sent a few of them to Angela, and she had asked the ones I sent her already. But there was a few more I wanted to kind of ask while you're here. One thing, this is one question we got from readers. If I get the vaccine, do I still need to wear a mask after the second dose? Can I still spread COVID-19 even though I should be immune to it? My impression was that it was yes to the first question and unknown to the second, but I was wondering if there's kind of any other information you have there, or even kind of, I don't know, any forecast of how long we'll be wearing masks.
Yeah, you were correct on those answers. Yes, we would recommend continuing to wear a mask because we're still not sure if you can asymptomatically acquire the virus despite the vaccine and pass it on to others. So for the time being, until further notice, the mask policy is still going to remain in effect.
Patrick, there's a question in the chat if you'd like to.
Mr. Bell says, as for reproductive side effects, how common are they? Are they primarily in men or women? And if I get the vaccine and I do not give it to my 14-year-old daughter, will she still be protected through herd immunity? Dr. Cahill?
I don't think anybody knows the long-term reproductive side effects, but they would not be predicted to be anything significant based on our knowledge of this vaccine technology. And that's really all we can base these recommendations on at this point, given the fact that this has only been around for a few months. There would not be, as far as I'm aware of, any predicted long-term risk of infertility. And I mentioned the pregnant population beforehand. That's a group that we still don't know a ton about, but it's likely that this will end up being very safe in that population as well. In regards to the question of the herd immunity, you know, I would recommend vaccinating people that are in the age range that it has been approved for, essentially. I wouldn't count on herd immunity just because 3 out of 4 of our neighbors, for example, have gotten the vaccine. I think it's still everybody's individual responsibility to make sure that they're not at risk of asymptomatically acquiring it and passing it on to others.
This is Patrick. I'd be remiss if I didn't mention sort of planning going forward, because clearly not everyone is going to have access to a computer. Not everyone is in the same place in terms of being able to communicate with them and having them be able to understand the information. So we have some resources available to us in our community, which we're really fortunate to be able to utilize. I actually just got an email from the state saying that they have now identified 2 what they call community outreach specialists, which will be provided to specific to the greater Norwich area and the Uncas Health District. Those folks, one will be fluent in Haitian Creole and one will be fluent in Spanish. So those will be 2 folks that we will certainly be using around messaging, communicating around clinics, and hopefully assisting them if they need to get information on scheduling. We also will have to continue to work on how we will get access for those people, or provide access for those people that may not have access to a computer, and we'll need to schedule either by phone or in person. So that's something that we're clearly thinking about moving forward. But you know, I know when we describe how people are going to do this initially, there's a lot of talk about, you know, doing it through the internet and uploading rosters and, you know, having computer skills that many of us struggle with, whether it be due to age, due to a language barrier, due to education, whatever the case may be. We do not want to neglect any part of our community in terms of getting access to vaccine. So that's going to be a process that we're going to work through, and not the least of which is Norwich Human Services and Leanne Gomes. We also have our community resource coordinators and TVCCA that we've been utilizing, both the hospital and the federally qualified health centers. They have resources around language and communications that are you know, things we will as a community need to tap into. But I just want to acknowledge that we know that those folks are out there that will need additional help, and we're going to do everything we can to make sure we reach out to them. And in fact, many of the people on the call will probably be ones we'll be asking for assistance. Dr. Cahill did put his information in the chat with his email address, which is patrick.cahill, Cahill, @hhchealth.org. And mine is Patrick McCormack, and my email, I've always said, it's unique. It's DOH, like Director of Health, @Uncas. So it's not the PATRI, Angela, it's the DOH @UncasHD.org. And I've always said, I think they gave me an email so that if they fire me, they can just give it to the next person who takes the job and they don't have to change my name in the front of it. And I've also heard that it's Doe, like The Simpsons, which is a very good way to remember it. So feel free. I mean, certainly you can reach out to us at any point in time with more questions, and I'm sure you'll have more, and I'm sure we'll need to do more research to get you more information, at least from the health district perspective, because like I said, this evolves so quickly and it's so fluid that each day we'll gather a little bit more information, and hopefully it'll be for clarity and not for confusion.
So we're coming up on our time. Does anybody else have any last minute questions?
I just had one quick follow-up. I know Patrick McCormack, you had mentioned kind of with the questions about allergies that, you know, there usually is an ambulance, you know, on site in case there are any issues. I don't know if you can kind of talk to how that might vary, like what different sites might be doing, whether you're getting it at a health district or at a hospital or at a nursing home, you know, what you've been hearing in terms of kind of precautions and, you know, in the probably off chance there is a reaction.
So we always, you know, our protocols are always to have basic thing, and we always have a nurse on staff because they're going to be vaccinating you in most cases. We have 3 nurses. We're really fortunate now on our staff as we speak, thanks to grant funding. And they do have things like EpiPens available. So we have those resources, whether there's an ambulance or not. But we've also had a great relationship with providers such as American Ambulance. And they've even had agreements where if it's a location in their service area, they will post an ambulance in many cases for us outside of the clinic, and they'll hold their crew there. And then if their crew is called out to an emergency, the crew will leave and they'll replace the crew and put somebody else in that same place for us. So while they're not specific to our location, it's their way of helping to provide resource if it's needed. And then clearly in our communities where American isn't the first responder or the EMS provider, then we will work with that local fire department to identify who the EMS provider is and just make sure we have a plan in place so we can call for help if we need it. The other, you know, obviously if it's a hospital or a federally qualified health center, they'll have different resources than we would. But the goal is to make sure that, you know, we have the basic response plan in place should somebody need assistance right away. I would also be remiss if I didn't thank Angela Adams and the Greater Norwich Area Chamber of Commerce for continuing to host these events. You know, they provide this resource and people take it if they need it. And I continue to just appreciate the fact that that's done for us, because the list of folks that are on Angela's you know, range of people she can connect with is actually better, if not greater than anything we could have done. So it's great, and it's great to be able to connect with the business community in that way. I also thank you know, Backus for always supporting me and supporting my district when we need help, because the clinical aspect of this is something I can't always speak to. So the fact Dr. Cahill, who I'm sure is incredibly busy, takes the time to do this with me is very much appreciated as well. So thank you.
I actually have one more question really quick. I learned the other day that employees at the healthcare facilities, we can't mandate them to receive the vaccine because it's not registered and it's EUA. Do we know at what point, if the data continues to be consistent with the trials, so if we continue to see, you know, a greater than 95% efficacy and the safety remains the same, what N do we have to reach for the vaccine to become registered versus an EUA rollout?
I don't know. That's a great question. Yeah, it is still not mandated, or it won't be mandated in the near future because of the like you mentioned, the fact that it's an EOA and not fully approved.
Thank you.
I like Dr. Cahill's answer because I have the same one. I couldn't. And just so folks know, Edie, her role over at the Three Rivers Community College nursing program is why she is so intelligent in the questions she asks and why she's so capable of stumping me on these calls. Yeah, I'm always happy to get the answer for you, but you know, Edie's just incredibly smart about the questions she asks, because those are the questions that we should be able to get an answer to. So thank you.
Okay, is that any other questions? Dr. Cahill, Patrick, thank you both again for coming on. As all of you know, the Chamber is here as a resource if you have additional questions, or if you'd like to have future panel discussions on any specific topics, please let me know and I'll make sure I try to plan those for you. I'm sure we'll have some more updates coming up, probably even another hour or two. You had mentioned, right, this afternoon, there's going to be some more updates. So we'll continue to get the information out there. We'll continue to be a resource and connect with the people that we need to connect with. So I appreciate you all being on the call, and I hope you all have a happy holiday.
Thank you so much.
Thank you. Take
Thank you.
care.